Hello, everyone. Thank you for joining us. My name is Sukhpreet. I'm I'm the Assistant Program Director for the BC Center on Substance Use Addiction Medicine Fellowship. Again, thanks for joining us here. It's a new talk from Dr. Britt-Heidi, who is a fourth-year resident in emergency medicine in the Kelowna program, who's taking a year away from that to join us and complete the Addiction Medicine Fellowship, which is great because we know that the intersection of addiction medicine in the emergency department is so exists to a significant degree. And she's going to be giving us a talk on alcohol withdrawal management, which is going to review the literature and be a bit of an update for all of us who aren't able to stay on top of everything. So thank you, everyone, for joining us, and go ahead, Dr. Bailey.
Thank you very much for the introduction, and thank you to everyone for tuning in. Everybody knows now, my name is Britt Bailey, and I'm a current fellow, and I'm also an emerge resident in R4. Today, I want to speak about the outpatient management of alcohol withdrawal. I hope to provide an overview of the literature that informs our current management strategies, discuss novel therapies under investigation, and review current guideline recommendations. I am certain questions will arise. Please feel free to jump in and interrupt at any time. I have also saved time at the end for discussion. There are also multiple experts far more knowledgeable than myself in this field here presently, and I invite you all to jump in and respond to any questions that come up. Questions can be posted in the chat while I present, and if you feel comfortable answering any of the questions, feel free to do so in the chat. In our Emerge Grand Rounds, it's yielded very fruitful chat discussions. If there's any technical difficulties throughout this presentation, I have Raman's number, and we will troubleshoot and go right back into the feed. I've had some connectivity issues this morning. I'd like to thank Drs. Isabel Miles, Dr. Paxton Back, Dr. Justin Coe, and Dr. Tyler Wilson for reviewing my slides and providing some feedback. I really appreciated some of the insights they provided and some of the feedback they gave me. I've decided to present today on a very common presentation. Over the course of my fellowship, I've noted variability in practice patterns. This has caused me to feel unsure of my practice and management choices at times. As such, I wanted to investigate the guidelines supporting outpatient alcohol withdrawal treatment strategies and better understand the evidence behind them. I initially sought out to do a review of all acute alcohol-related complications, and then I pared it down to inpatient and outpatient, and just the volume of information to cover made it impossible to talk about all of those things and do a proper deep dive. And so I've decided to really focus in on outpatient management. I think it's an interesting question because it's a time where we're sending patients home where we can't monitor them closely, and that makes it particularly relevant to feel really comfortable and safe in our management strategies. A preceptor of mine often emphasizes the importance of understanding three key elements when designing a management plan. 1, pharmacology, 2, evidence and guidelines, and 3, safety. I hope that by exploring these topics, it will help you provide a thoughtful, safe, evidence-informed care plan with which to support your patients. In brief, I'm going to outline an evidence-informed approach to risk stratifying the patient with alcohol use disorder who's at risk for experiencing a complicated form of withdrawal, as this is obviously very important in determining which patients we can actually manage as outpatients. I then want to speak about pharmacologic therapies that can be utilized and some of the evidence and recommendations around these therapies. I really wanted a deeper understanding, particularly of the medications we use, as this is a time where we may not be able to monitor patients, as I mentioned already. There are a lot of topics I would have liked to have talked about, but I will be focusing on outpatient therapies only. I will not be talking about relapse prevention or inpatient therapies today, but that can maybe be a topic for another talk. I've done my very best to summarize the available literature around topics in question and have kept careful records of the papers I cite. Inevitably, questions may come up pertaining to detailed methodology or outcomes that I am unable to answer directly. If this occurs, I commit to follow up with you with an answer to your question and the PDF of the study in question. So for some context, alcohol is the most commonly consumed substance in Canada, with 78% of Canadians 15 or older reporting past year alcohol consumption. Interestingly, of those consuming alcohol, approximately 1/3 report consuming above the Canadian low-risk drinking guidelines at least once a month in the past year. A significant proportion of presentations to the emergency department have been linked with alcohol, with an estimated 1.18% of total number of emergency department visits in Ontario being attributable directly to alcohol over a 10-year study period. Furthermore, this is a population at high risk of morbidity and mortality. All-cause one-year mortality among patients in Ontario presenting to the emergency department with alcohol-related presentations ranges from 5 to 9% and was found to increase amongst those with more frequent emergency department visits. You can imagine the topic of outpatient withdrawal management is very interesting to me in my Emerge life because it is very it's a huge part of the decision-making disposition of our patients. It's also become a very interesting question to me in the Rapid Access Addiction Clinic at St. Paul's when seeing patients like this and making that initial decision around risk stratification. I'm going to reference guidelines throughout this presentation, and when I'm referring to guidelines, I'm referring to this, the provincial guideline for the clinical management of high-risk drinking and alcohol use disorder. This was published, updated in 2019, and is our local guideline and reference tool. So if we talk about risk stratification first, the diagnosis of alcohol withdrawal syndrome is based on DSM-5 criteria, as we all know. In brief, first, a sudden cessation or decrease of alcohol consumption. 2, physical symptoms and/or anxiety. 3, clinically significant distress or impairment, and 4, not being explained by anything else. When I talk about complicated alcohol withdrawal or alcohol withdrawal syndrome, that's defined as withdrawal that includes delirium tremens, withdrawal seizures, or ongoing clinical withdrawal despite significant benzodiazepine administration. Now, it's estimated that 50% of individuals with long-term alcohol dependence will experience some degree of withdrawal upon cessation of alcohol. Of the 50% of individuals that actually experience withdrawal, about 8% experience a transient visual, auditory, and/or tactile hallucination state. And then approximately another 10% experience withdrawal-related seizures. Now, of that 10% of patients experiencing withdrawal seizures, if left untreated, approximately 1/3 of individuals are at risk of progression to delirium tremens. Both seizures and delirium tremens are associated with significantly increased morbidity and mortality. The key of risk stratification is to try to determine which patients are actually at risk of these complications and which are not. Understanding where your patient most likely fits on a spectrum of risk from no withdrawal symptoms at all to experiencing severe life-threatening complications helps you determine the most appropriate disposition and pharmacologic strategy for your patient. It is essential to be able to risk stratify the patient with alcohol use disorder to help determine their risk of complicated withdrawal and to help inform their disposition and management, as I just said. In broad general terms, factors on history that are associated with an increased risk of complicated alcohol withdrawal are a past history of seizures or DTs or delirium tremens, having multiple comorbidities, being of older age and/or having a longer duration of drinking and/or a higher number of previous detox or withdrawal events. All of those often go hand in hand. A history of structural brain lesions or baseline seizure disorder. And then on physical exam and on investigations, dehydration and/or abnormal electrolytes, clinical withdrawal symptoms despite an elevated blood alcohol level, and elevated hepatic transaminases. These have all been associated with increased risk of complicated alcohol withdrawal. Understanding the relationship between these risk factors and overall risk is difficult in any clinical scenario. A 2018 systematic literature review in JAMA, that one of the rational clinical examination papers, sought to assess the accuracy and predictive value of symptoms and signs for identifying hospitalized patients at risk of complicated alcohol withdrawal. You may recognize many authors on this paper. The authors analyzed 14 studies, total of 71,000 patients, evaluating single and composite measures of severe withdrawal risk. No single symptom or sign was associated with exclusion of complicated alcohol withdrawal syndrome. Unsurprisingly, composite scales that measured multiple signs and symptoms were more useful in estimating an individual's risk than any one or few individual signs or symptoms. Multiple different composite measures you may have previously heard about or read about being used in previous studies were compared. This is things like the AWS or alcohol withdrawal scales, or the LARS-10, the Lübeck alcohol withdrawal risk scale. In the end, the prediction of alcohol withdrawal severity scale, or the PAWS score, was found to be the most useful, with a sensitivity of 0.93 and a specificity of 0.99, and a positive predictive value with a PAWS score above 4 of 93%, and a negative predictive value with a PAWS less than 4 of 99%, assuming a baseline incidence of complicated alcohol withdrawal of 5% in hospitalized patients. Now, a little bit more about this PAWS scale. It was created by a research group out of Stanford University in 2014 and prospectively validated in 2015. It's a 10-item cumulative scale with a maximum score of 10, wherein a score of less than 4 indicates a low risk and a score of greater than 4 denotes a high risk for severe complications of withdrawal. The QR code there will get you to the MD Calc app, or the quick calculator for this. Unlike common clinical prediction tools, all measures on the scale are weighted equally. For example, a past history of delirium tremens is weighted equally to a past history of attending AA meetings or live-in treatment. This is important to understand because, as we know, a history of prior delirium tremens is very significant and aligns with our understanding of increased risk due to a demonstrated past imbalance of GABA and glutamate, whereas individuals may attend treatment for a variety of reasons at a variety of different severities of alcohol use disorder, which may be significant if they have a 20-year history of drinking and multiple presentations to treatment represent longevity of disease, but maybe less relevant and maybe not weighted as equally in your clinical decision-making process if they're early in their disease process and presenting to maintain a contract for work or due to a driving infraction or otherwise. Additionally, PAWS entry criteria is being 18 or older and being admitted to the initial study PAWS entry criteria was being 18 or older and being admitted to a general medicine floor and not having a history of alcohol use disorder, i.e. it was sort of an all-comers to the ward. In this way, the risk prediction tool uses an all admitted patients as the denominator and not the specific population of interest, i.e. those with alcohol use disorder. So in this way, the PAWS score has not actually been studied amongst outpatients, detox patients, emergency department, or ICU patients. It's also not been studied in youth or pregnancy and has not yet been studied in patients that do not communicate in English. The tool is not considered suitable for self-assessment due to concerns around patients' interpretation of seizures and delirium tremens. And finally, this tool does not take into consideration comorbidities, abnormal investigations, medical illness, age, and frailty, and clinical discretion is therefore advised in these circumstances. So the literature would suggest the PAWS is the most robust tool we have to risk stratify patients for complicated alcohol withdrawal syndrome. And this is reflected in our local BC CSU guidelines, which recommend routine use and documentation of PAWS to risk stratify patients. Furthermore, the BC CSU guidelines extrapolate the risk stratification provided by the PAWS score and use it as a basis for disposition decision-making. This risk stratification is based on the findings of the PAWS validation study, which showed that a negative PAWS score less than 4, 0.5% of patients developed moderate or severe alcohol withdrawal syndrome, versus a positive PAWS score equal to or greater than 4, 93% of patients developed what they clinically described as moderate or severe alcohol withdrawal syndrome. Specifically, patients with a PAWS low risk score less than 4, the recommendation is that we consider them for outpatient withdrawal management with ongoing close follow-up. Patients with a PAWS score 4 or greater, the BC CSU guideline recommendation would be for inpatient management. As I already mentioned, it's important to emphasize that the PAUSE score is a clinical prediction tool and not a rule, and therefore patients should be considered on an individual basis, and considerations such as comorbidities, frailty, outpatient safety, ability to understand and follow directions, and the availability of a very close follow-up should factor into decision making. Next, I want to talk about actively measuring withdrawal severity in the present moment. The most commonly used tool to quantify the severity of alcohol withdrawal is the CWA. It has been validated in mild and moderate alcohol withdrawal, and it's notable that patients with seizures were excluded in the initial studies. It was derived in the 90s, initially as a research tool. And it's based on subjective or opinions of the observer talking to the patient about their reported symptoms. Vital signs are excluded, and this is particularly relevant because we often consider it key clinically to recognizing severe alcohol withdrawal syndrome. Once the CWA is positive, the patient is already experiencing symptoms of withdrawal, which means you may miss the window to provide medications for prophylaxis if risk stratification is based on CWA alone. Now, notably, CWA combined with symptom-triggered benzodiazepines is considered the standard of care for withdrawal management and has been associated with reduced total amount of benzodiazepines administered. The objective alcohol withdrawal scoring concepts, often called the objective CWA, is a never studied, not validated tool that we as addiction medicine providers will sometimes use in specific instances. For example, when there's communication difficulty, when there's suspicion of benzodiazepine seeking, and or with language barrier. And basically the concept is that based on objective findings such as tachycardia, hypertension, diaphoresis, restlessness or tremor, that increased benzodiazepines would be dispensed. But like I said, this is not yet studied. And I just want to emphasize that although those are important clinical factors when assessing active withdrawal, this has not been validated or studied formally. Now that we have risk stratified our patient and noted that they have a PAUSE score less than 4, it is time to discuss how we will support them through the process of alcohol withdrawal. It will be essential to ensure, like we said, follow-up, that they are aware of community support resources, that they have a support person who can hopefully be with them, and that they know where to present for help should they have any concerns or worsening condition. After those pieces have been established, the next question is around pharmacologic therapies to support their withdrawal process, which is where I would like to focus our discussion today. I encourage you all to think about recent cases you've seen in your own practices and how this discussion might apply to them. Alcohol withdrawal is interestingly the most common time for a person to relapse. Studies have repeatedly demonstrated safety of outpatient withdrawal management in the appropriately selected low-risk patient with appropriately selected interventions. It's emphasized that adequate management of withdrawal symptoms, including pharmacotherapy when appropriate, can increase the likelihood that patients will achieve their treatment goals. That is not to say, though, that pharmacotherapy is necessary. There's a lack of consensus and clear guideline regarding outpatient management of patients experiencing mild withdrawal symptoms, and some practice guidelines would advocate for supportive care alone. In this way, it really emphasizes how important it is to have a solid understanding of the evidence, pharmacology, and safety and the guidelines underlying outpatient alcohol withdrawal management. The BC-CSU guideline, published in 2019, recommends the use of several non-benzodiazepine agents to support patients with low-moderate withdrawal at low risk for complicated alcohol withdrawal syndrome. This is listed as a strong recommendation and is informed by moderate quality evidence. I'd like to break this down a little bit and better understand the information around this recommendation. So basically what I'm going to do, I'm going to go through and talk about each of these agents. So first, if we talk about carbamazepine. Carbamazepine has been used in Europe for over 35 years to manage symptoms of alcohol withdrawal. Interestingly, there has only been a single study, the Malcolm 2002 study, which has looked at the outpatient use of carbamazepine. This study did not find a difference in CWAS score reduction between lorazepam and a 5-day taper of carbamazepine. Notably, it was not designed as a non-inferiority trial. It did, however, find a difference in rebound withdrawal symptoms after discontinuation of lorazepam and noted that study participants had a 3 times greater risk of having their first drink while experiencing this rebound withdrawal. Unfortunately, it does not seem that there have been any studies to date comparing carbamazepine to placebo. This is a bit unfortunate as the population we are extrapolating this data to is low-risk outpatients for whom we would be less likely to prescribe benzodiazepines and in which we may consider supportive care. It is still, though, interesting to compare them to what we would consider the gold standard therapy. Additionally, the Stupiak paper, talking about some of the inpatient research, failed to report adverse outcomes. The Gallant paper noted a single seizure in the oxazepam group, and the Schick paper noted a single case of delirium tremens in the carbamazepine group. Overall, the available literature seems to suggest that carbamazepine may be similar in efficacy as lorazepam for the outcome of CWAS score. The generalizability of this information into the outpatient population, though, is unclear, as there has only been a single outpatient study with relatively small size and no comparison to placebo or other recommended outpatient therapy options presently. A 2020 systematic literature review considering the role of non-benzodiazepine agents to support withdrawal went through and systematically analyzed risk of bias for the randomized control studies involved or that investigate all of these therapies. And for the papers around carbamazepine, the Stupiak and Gallant papers were at high risk of bias, and the older Schick paper was considered at moderate risk of bias due to the above noted concerns. I think it's an important aspect of medication safety to understand the basic pharmacology of the agent in question. This can help you anticipate the duration of effect, factors that impact duration of effect, elimination, and the timing of peak serum levels, which may help anticipate the highest risk time, particularly for sedating medications. In the case of carbamazepine, the half-life can be up to 65 hours, and it is increased in renal impairment. Its peak is unpredictable, but is generally estimated at 4 to 5 hours. It is metabolized through a hepatic mechanism, and elimination is renal. Sorry, there's a typo there. Important considerations are that patients of Asian ethnicity can be at increased risk for toxicity due to different enzymes and metabolism that can exist. There are also multiple case reports of Stevens-Johnson syndrome, a severe dermatologic condition, particularly at higher doses at longer durations when carbamazepine is used in seizures. This has not been reported in the alcohol withdrawal literature, but it's important to note just because it hasn't been reported doesn't mean it's not a risk and hasn't occurred. It could just simply be that it's not been investigated or people have not submitted case studies. And then common side effects listed, and those most commonly reported in the studies I mentioned are itchiness, nausea, vomiting, dizziness, confusion, sedation, and rash. So to sort of summarize this and what I took from it, and I'll be curious if other people have different feedback, but what I took from it is that there's only really been a single outpatient trial. It was a small sample size and there was no placebo control. The results from the literature that combines both inpatient and outpatient data may demonstrate a signal of benefit, particularly at the second half or the later part of withdrawal. All studies were of very short duration, and although low serious adverse event profiles were reported, there were frequent nausea, vomiting, itchiness, and severe theoretical concerns that can be associated with these agents. There's insufficient evidence to understand the role in seizure prevention, but despite this lack of evidence, like many things in addiction medicine where there is not a lot of information, this is listed and supported in the BCCSU guidelines. For me personally, I will consider carbamazepine in low-risk patients with no contraindications only in a practice-supported setting with close follow-up. And what I mean by that is this is probably for me not going to be my first line agent because it's not what I've trained using as much and it's not what I'm as comfortable with. That said, I have seen staff use it, and I am now, after reviewing this, going to make a concerted effort to have more discussions with my staff around carbamazepine use to better understand when they're using this agent. In reviewing my slides and discussing with staff and co-residents, my understanding is that this has sometimes been applied in patients that don't like gabapentin or have previous adverse reactions or reasons they don't want to use gabapentin. And so I think that will be the population in which I cautiously apply carbamazepine. Next on to gabapentin. Personally, this has been an agent I've noted to be used extensively to support outpatient mild low-risk withdrawal with a PAUSE score less than 4. Interestingly, despite its frequent use, there have been limited studies examining its use in the outpatient setting. In fact, after extensive literature review, I was only able to identify these 4 randomized controlled trials that examine the use of gabapentin to manage outpatient withdrawal. I've highlighted the key findings in these papers. Strengths are the comparison to placebo, as well as multiple different benzodiazepines and anti-epileptics. The most marked results were noted in the 2009 MyRic randomized control trial, which noted a reduction in CWA scores, cravings, anxiety, sedation, and drinking in the week immediately following discontinuation of alcohol. Additionally, an improved effect at higher dose seemed to be observed. Notably, the study is significantly limited by the small sample size, the lack of comparison to placebo, the relatively healthy, low comorbidity population studied, and the ready access to daily follow-up, which may limit its generalizability. There is also no study comparing to a standard of care low-dose, symptom-triggered benzodiazepine therapy. Furthermore, the doses of gabapentin used are low when compared to relapse prevention dosing of 600 milligrams PO/TID. Additionally, only 68 of the 100 patients completed the entire study protocol and follow-up appointments until day 12, and 2 participants had a probable single withdrawal seizure. Notably, the studies that did not detect a difference in outcome were not designed as non-inferiority trials. I think a final important consideration is the duration of treatment. The longest course of treatment studied, specifically evaluating supporting outpatient withdrawal, was 6 days. Now, if we go back to that 2020 systematic literature review that assessed bias in randomized controlled trials looking at agents to support alcohol withdrawal that were not benzodiazepines, it noted that both the MyRic and the stock studies were at high risk of bias due to some of the above noted concerns. As far as gabapentin pharmacology, the half-life is estimated to be 5 to 7 hours with a peak around the 2 to 4 hour mark. Gabapentin is renally excreted and can have markedly longer duration of action in those with renal impairment. Gabapentin is thought to increase the risk of imbalance, slurred speech, and sedation, and there is concern in patients who continue to consume alcohol that the effects of gabapentin do compound the clinical effects of alcohol. Despite this, gabapentin is often described as a safe medication with limited abuse potential. This is, however, not entirely the case. As we have heard in multiple recent presentations, gabapentin does have misuse potential. It is quite cheap to purchase on the street, and a concerning 2015 study out of the States in Kentucky demonstrated strikingly high rates of gabapentin positivity on toxicology reports from fatal drug overdose victims, with a rate of 22%. This is an area that has a high rate of gabapentin misuse and higher than BC presently is thought to. And actually, it's a Schedule I substance now in Kentucky. Studies have, and so I think that's important to understand. Studies so far have failed to demonstrate an increased risk for gabapentin misuse amongst patients with alcohol use disorder. They've also failed to show an increase in adverse events in patients with alcohol use disorder taking gabapentin, but a lack of evidence in this case does not infer safety. Anecdotally, colleagues working in Saskatchewan, Manitoba, and Ontario report gabapentin misuse, dependence, and diversion. That has not, again, anecdotally been noted in the case of BC, to my knowledge, frequently, to my knowledge. However, further studies are needed. And lastly, an important note, there's an absence of evidence evaluating seizure prevention, and like I mentioned, seizures did occur in the groups treated with gabapentin in the randomized control trials looking at this intervention. For me, the take-home points are really that our current practice around the use of gabapentin to support outpatient withdrawal is based on limited, moderate, or low quality evidence with a high risk of bias. Safety concerns with diversion and oversedation exist. There's no evidence for the use of gabapentin in the support of outpatient withdrawal past 6 days. For me, this is going to change my practice in the sense that I will only consider this in very low risk patients. I will prescribe a short duration of therapy, and I will ensure close follow-up. I will also provide specific harm reduction education around concern for ongoing drinking or combination with other sedative agents such as opioids from an overdose risk perspective. Next on to clonidine. Clonidine is essentially acting alpha-2 adrenergic agonist that can suppress persistent noradrenergic symptoms. All this to say, it can reduce hypertension and tachycardia that are associated with alcohol withdrawal. Interestingly, there have only been 3 trials considering the benefits of clonidine in alcohol, 3 randomized control trials, considering the benefits of clonidine in alcohol withdrawal management, and they are all quite dated. They also had small sample sizes, increasing the risk of bias, and there have been no comparisons to a symptom-triggered benzo gold standard regimen. Helpfully, clonidine was compared to multiple benzo agents as well as placebo. Notably, patients having had seizures in the past were excluded from these trials. This would, in theory, select for a lower risk population, more similar to our intended outpatient population. Additionally, these studies measured impacts on blood pressure and heart rate, known effects of alpha-2 adrenergic agents. And they did this either directly or through inclusion in alcohol withdrawal assessments. Withdrawal severity scores can, although CWAD doesn't, include an element of abnormal vital signs, and therefore the change in heart rate and blood pressure caused by clonidine may have been falsely reassuring. Understanding these important limitations, clonidine reduced withdrawal scores in 2 of the 3 studies, along with heart rate and blood pressure. The Adenoff study did not report adverse outcomes at all, and the Baumgartner studies reported no serious adverse outcomes. In that 2020 systematic literature review assessing bias that I keep bringing back up, the Baumgartner studies were at high risk of bias, and the Adenoff study was considered at moderate risk of bias because of some of the above noted concerns. As far as clonidine pharmacology, its half-life is moderate at around 16 hours. Its peak is between 1 and 3 hours, and it's metabolized hepatically and eliminated through the renal system. Really important considerations with clonidine are that it causes sinus node dysfunction and can cause marked decrease in heart rate and decrease in blood pressure, and along with that, orthostatic changes. It can also be associated with sedation, and because of these effects, has a significant fall risk. Lastly, like I mentioned before, it has no evidence in seizure prophylaxis. So in summary around clonidine, my take-home points are that there have been no outpatient studies. Studies that have been completed excluded patients that have had a previous history of seizures. Right now, there's insufficient evidence and there's no theoretical basis that this medication provides seizure prophylaxis. Short durations of therapy, less than 4 days, are what have been studied. And it's really unclear if clonidine has more of an effect than placebo. I have some concerns around the pharmacology from a fall and sedation risk perspective in a cohort of patients that are already at risk for falls and sedation, particularly in the elderly patients. For me, this is changing my practice because I'm going to be proceeding with a lot more caution prescribing clonidine. And to be honest, I don't know if I will be doing this very often. In the rare patient where I find they have contraindications to other agents that I would prefer to use, I will be ensuring that they are healthy, that they have an adequate baseline blood pressure and heart rate. I will be providing a very short prescription, less than 4 days, and significant education around safety, harm reduction, and ensuring close follow-up. Next is baclofen. I think this is a really interesting topic, and I'm excited to talk about it. Baclofen is a GABA receptor agonist that is primarily prescribed as a muscle relaxant. I do this in Emerge sometimes, so there's no evidence for it in back pain, but sometimes you get pushed to use it in rare circumstances. So I found this interesting. But it's also been used for treating alcohol use disorder. While not commonly prescribed in North America, it is an approved alcohol use disorder pharmacotherapy in France and is commonly used off-label in Australia and Germany. A single outpatient trial, the Adolorado trial, with an N of 37 patients, has been completed comparing baclofen to diazepam. It did not find a difference in mean CWAS scores. It was limited by small sample size and single-blind design, with participants being aware of the type of medication they received. No serious adverse effects were noted. The remainder of the studies were inpatient studies. As far as a risk of bias, the Adorado study was noted to have a moderate concern for bias, and the Lion study was considered to have a high risk of bias. Interestingly, the remaining 3 studies were actually analyzed as low risk of bias. Now, a 2019 Cochrane review also looked at this question. And what they noted was that none of the included studies reported the primary outcome of alcohol withdrawal seizures, alcohol withdrawal delirium, or craving, important factors and outcomes that we would like to know about as addiction medicine providers. The comparisons of baclofen to placebo, diazepam, and chlorodiazepoxide all demonstrated no evidence of difference in mean CWAS scoring. None of the randomized controlled trials provided information on random sequence generation or allocation concealment. Therefore, they were assessed as an unclear risk of bias. 2 RCTs were not of double-blind design and had a high risk of bias and blinding. I just find it so interesting that we have more studies on baclofen than on some of the other agents that we use more commonly. As far as pharmacology, it has a short half-life, 5 to 6 hours, a peak around 1 hour. Its metabolism is not well understood, and it's eliminated through the renal system in feces. Baclofen can be associated with vertigo, drowsiness, paresthesias, and rigidity. There is no evidence in its ability to prevent seizures, and notably, baclofen can have severe physiologic dependence in patients with intrathecal baclofen pumps. That data has not been extrapolated to long-term use of baclofen orally in the outpatient setting, but I think it is an important future consideration. So for me, my take-homes around baclofen are that really we have no evidence for a difference between placebo and benzos. The studies that have been performed have a small sample size and an unclear risk of bias. There have been completely inadequate reporting of serious adverse effects I would like to know about before prescribing a medication. Its routine use is not supported in the BCCSU guideline. So for me, I will not be prescribing baclofen for alcohol use disorder, and hopefully not for back pain either. But I will be watching evidence along this line, and I hope to have discussions with staff in future around this agent if it comes up in discussion. And then my last agent that I want to talk about before I am nearing the end of my presentation is valproate. There have been 3 open label randomized control trials examining the use of valproate. They were all conducted within an inpatient population. 2 of 3 used valproate in addition to a benzo, and a single study used valproate monotherapy to compare it to symptom-triggered benzos. There was no direct comparison to placebo monotherapy. Divalproex or valproate and benzodiazepines did not show a significant difference in efficacy, but compared to placebo, there was a signal for more rapid decline in CWAS scores. So more rapid, but then no real average difference. The valproate group required, in the RIU study, the valproate group actually required a little less rescue oxazepam, and that study also reported increased sedation. However, no other serious adverse outcomes were noted across the 3 studies. As far as risk for bias, all 3 of these were analyzed to have a moderate concern for bias. For pharmacology, the half-life of valproate can be up to 19 hours. Its peak is slow at 4 hours. It is, again, like every other agent I've discussed today, metabolized hepatically and eliminated through the renal system. Common side effects are around GI upset, and that was the most commonly reported side effect reported in the studies I previously mentioned. It is not known to have a diversion or misuse risk, and it is not thought to potentiate the effects of alcohol. It is notably teratogenic, and presently there is insufficient evidence to support a reduction in seizures at the doses used in the setting of alcohol withdrawal syndrome. So in summary around valproate, there have only been limited small inpatient open label studies. There's insufficient evidence, in my opinion, to routinely use this therapy. I mentioned the insufficient evidence around seizure prophylaxis, and its routine use is not supported in the BCCSU guidelines. For me, I'm not going to be routinely using this agent, but I will watch for future studies around this topic. I really think the theoretical basis of using an anticonvulsant therapy in the setting of alcohol withdrawal management is interesting and would be great if it could pan out in the literature. It'll be something I'm watching for ongoing. The very last thing I wanted to talk about was the concept of benzodiazepine loading. I've put this in the outpatient section, but I think that's probably up for debate. I have seen this used in both the in and outpatient settings. I've also anecdotally heard it spoken of as a risky intervention. I would encourage any more experienced clinicians tuning in to jump in with their experience after I review some of the evidence around this intervention. Oops. Sorry. I'm going to start with the pharmacology here. Diazepam has a very long half-life. It's also thought to accumulate with multiple dosing. It has a rapid peak between 15 minutes and 2.5 hours. It is associated with sedation. Added caution in the elderly patients who are frail or at risk of falls is important. It can be associated with confusion. It's metabolized hepatically and eliminated renally. The reason I wanted to bring up the pharmacology of diazepam first is that I think it's important to note that it lasts for a really long, it comes on quick and lasts for a really long time. And that's important when we talk about the concept of diazepam loading. This is basically where alcohol withdrawal is treated with IV or oral diazepam that's rapidly titrated based on symptoms until the patient is calm and or mildly sedated. Oral diazepam, usually at a dose of 10 to 20 milligrams, can be repeatedly administered or has been described to be repeatedly administered at intervals of 1 to 2 hours until the patient is either calm or mildly sedated. Oral diazepam can be used for this approach because it has a shorter time to peak than oral chlordiazepoxide, lorazepam, and oxazepam, allowing it to be titrated relatively rapidly while avoiding oversedation. Because of its long half-life, it's hypothesized to also facilitate a smoother taper. Across the 6 published studies of oral diazepam loading to treat alcohol withdrawal, which included 244 patients, that included 244 patients. Diazepam loading was found to provide rapid relief of symptoms, reduce seizure incidence, and shorten the course of delirium tremens in those experiencing it. Strikingly, the authors of all 6 studies uniformly reported that none of the patients experienced significant adverse effects from the diazepam treatment. Adverse effects were not addressed in the 7th study. Together with the studies that used IV diazepam, these studies suggest efficacy, safety, and a pharmacologic theory behind which diazepam loading could be used on a symptom-based approach, theoretically to approach the patient that you are monitoring in your department or in your clinic prior to discharging home. The concern here arises upon discharge when patients may relapse into drinking or use other sedating agents. A long period of outpatient follow-up and monitoring is needed to truly ensure safety and anecdotally, in speaking with staff, I understand there have been cases locally with adverse outcomes in patients discharged after benzoloading. There are no case reports that I'm aware of to this effect. So in this way, the literature seems to demonstrate effect and safety, but it was a small sample size in an inpatient monitored setting. This is not supported or even mentioned in the BCCSU guidelines, and safety is completely unclear. The long duration of follow-up, or because a long duration of follow-up would be needed to truly assess safety, and therefore the local application is unclear. And I really, I think about this in multiple settings. I'm based in Kelowna for my Emerge residency, which is it is an academic center, but more of a community center setting. And so I think about places where maybe you don't have access to a RAC clinic the next day, and how nice it would be to get some seizure prophylaxis with an agent that has evidence for seizure prophylaxis into our patients with a slow gradual taper, can do the main bit of monitoring in the department or in the clinic, and then send them home to follow up in 1 to 2 days if immediate follow-up is not available. However, obviously, as I've mentioned, there are significant safety concerns here, and I don't think, as far as how this is changing my practice, I don't think that this is ready for routine prime time use. I do wonder about it in the super reliable patient that is housed, has a partner or somebody that can stay with them, that is committed to a plan of abstinence, and for whom you can complete very careful harm reduction education and can actually show up for follow-up. This is a topic I'm going to bring up with my staff throughout the remainder of my fellowship and try to have discussions around, because I'd really like to better understand the practice pattern around the use of diazepam loading. I can certainly see a role for it in the inpatient setting, where it may be helpful to have on initially to theoretically reduce your overall ongoing benzodiazepine use and risk for complicated alcohol withdrawal pictures, but that's not yet been thoroughly borne out in the literature. So as far as take-home points here, I think it's really important to have an understanding of the evidence, the guidelines, and the pharmacology underlying a management strategy when creating a management plan. For me, I'm going to continue and try to routinely use and document the PAUSE score and consider patient-specific factors when trying to risk stratify patients for outpatient therapy. I'm going to use the CWA for all encounters that I have with these patients to document the active severity of withdrawal. And I will probably complete it myself, or at least review the areas patients scored on ongoing. Consider supportive care. For me, I'm going to consider supportive care versus gabapentin versus maybe carbamazepine for pharmacologic support as an outpatient for a very short duration of time. I'm going to be cautious with clonidine, baclofen, and valproate. And I'm going to continue to think about diazepam and have conversations around diazepam loading for the outpatient setting. As always, close follow-up, psychosocial supports, harm reduction education are all essential prior to discharge. This is the end of my presentation. We now have 13 minutes for some discussion and questions. I will say, like I said at the beginning, there are some experts here much more knowledgeable than myself on some of these topics. So if my answer feels inadequate or you have more to add, please feel free to jump in. I think the entire group listening would really appreciate any expertise presently here.
Thank you, Britt. If we can open up to questions, people can unmute themselves or can throw them in the chat or the question box.
Maybe while we're waiting to see if anybody has any questions, Dr. Claire, can I ask you what your sentiment is on diazepam loading for the outpatient population?
Sure. So I think in an appropriately selected patient who has close follow-up and monitoring, that there's potentially utility in it, but I think it really is a small group of patients that it's appropriate for, recognizing that we're most of the time trying to avoid using benzodiazepines at all in the outpatient setting, given the risk of long half-life diazepam, people return to drinking, and that really, if you're thinking about diazepam, it does beg the question of whether they should be in an inpatient setting. So I think for certain patients that have clear contraindications or lack of response to other agents, and you feel comfortable managing them in the outpatient setting, that it's worth trying. But I think the other caveat is that it really needs to be a situation where you can really do the loading and have the person receive several doses and look okay from a withdrawal perspective, and then also be monitored for a period afterwards to ensure they're not sedated, and then still be lucid enough to get home. So it's sometimes a little bit difficult in practice to really have a patient who arrives early enough in the day to have it be used appropriately. But I think for certain patients, it definitely could be a good option when we know that the reality of our system is that there are limited inpatient withdrawal management sites.
Yeah, that's really helpful clinical experience to understand. Thank you. Okay, well, if we don't have any further questions, I'm putting my email in the chat. Sorry, I should have put it on the last slide here. And if any questions come up, feel free to contact me. I'm happy to try to work through them.
Awesome. Thank you, Dr. Bailey, for a very comprehensive talk, and one that I think will be useful for everyone who was able to attend.
Thanks so much for coming. Bye.